Majority of you are coming from a public health unit. Great. And the last question, what discipline do you currently belong to? Overwhelming majority registered nurses. Thank you everyone for participating, and now I'm going to hand it over to Dr. Gilchrist.
So I'm Chris Gilchrist, and with that introduction, we'll just jump right into things. And so I hope that over the course of this session, I have three main goals for us. The first one is that I hope that we're able to appreciate the high burden of nicotine dependence within the homeless population. I'm sure most of us have an idea about that, but I'm hoping that we can get some numbers to really appreciate the gravity of the situation. The other thing I'd like to do is talk about what are the barriers to smoking cessation within this population, because they're not exactly the same as those in the general population. And then we will take some time to talk about what are some of the strategies that have worked to help promote smoking cessation and effectively promote it, and where are things going to take us in the future. So to achieve that, we're going to talk a little bit about smoking and smoking cessation in general, and what the implications are for our health and for the general population as well as the homeless population. We're going to talk about the health status of homeless individuals and its implications with smoking. Talk about what are the roadblocks to smoking cessation, and then what are some of the potential strategies that we can use to effectively promote smoking cessation within the homeless population. Just because this is a webinar, I think it's going to be easier to do questions at the end, so please save them for then, and we'll have lots of time for questions and discussion. So to begin with, I think it's important to think about why do people smoke? And I think that my personal friends, Don Draper and Roger Sterling from Mad Men, they really exemplify these 2 points. Essentially, it's because it does something good and it's hard to stop. And if we think about the good parts to begin with, I think it's important that we realize that smoking does something good for these people. And without acknowledging that, it makes the cessation efforts very difficult, because if you can't replace what's happening that is doing good in their life, then the effort is likely to fail. And so if we think about what's good, we think about when people first start smoking. Often it's when they're young, it's to fit in, it's to impress someone, it's to look cool. And that notion of cool, I think, is an interesting one. And when I look at this picture here, I find it interesting because it's almost a Pavlovian response to seeing how cool Don Draper looks, that it makes me want a cigarette and a whiskey. And I've never been a smoker. I rarely drink whiskey. And I obviously know that this would be a bad idea. But I find it interesting that just the way you frame a picture um, change how things are portrayed and can make things seem more or less appealing in the absence of sort of that logical response.
Dr. Gilchrist, there are some comments in the chat room saying that they can't really hear you very well. If you can try moving the phone maybe closer to you, hopefully that will help, or turn up the volume on your phone maybe.
Is that better if I talk like this?
For me, it seems louder. Let's just wait a second and see if people can type in the chat box. If you could please just let us know if this is better.
This is how loud I can sort of talk. I'm right over the phone right now.
Okay. Okay, people are saying that it's better. Okay, thank you.
The webcam just for a minute, and take it from there. Okay. So back to the things that smoking does that's good. And so we talked about how people start out, but it's also a mechanism of how people continue to be social. And for many people, smoking is a social tie that they do with their friends. The other thing is what it does for them personally. And so for many people, this is a way to deal with stress, to deal with anxiety and low mood. And for these in-the-moment tasks or issues, at least in the minds of the smoker, smoking is something that will never let you down, and it's something that is immediately there. And so we have to think about how we can address these when we're thinking about how we can deal with smoking cessation. The other flip side is that even if people want to quit, it's difficult to quit. And so this is obviously multifactorial. It comes down to the physiologic dependence from nicotine and the codependence with other drugs like alcohol or coffee even. People may be self-medicating with things like anxiety and depression. And it may also help with people who have poor coping skills otherwise. They're limited social support in terms of both quitting or in terms of how they're interacting. And so I think it's interesting to think about the Mad Men world, the 1960s, because it's sometimes hard to fully empathize with smokers today because on the whole, smoking is a very socially taboo issue now. But if we think back to the world of Mad Men in the 1960s, where smoking was everywhere, it was pervasive, it was what people did, and there was almost no alternative. And if we think about how hard it would be to quit back then, what pressures that would have stopped you. One thing I'm going to say is that smoking in the homeless population is almost like being back in this world where smoking is just everywhere. And how can we support people to quit in an environment like that? So we talk about it in more detail, some of the issues that keep people smoking. So nicotine is at the forefront of this. So it's a social drug. It relaxes people when they're stressed. It can stimulate them when they're tired. And so it has this very paradoxical effect that it can do pretty much what you need it to do when you need it to do it. And it's very reinforcing because it acts quickly, both due to the drug itself and how we intake it through inhalation. And it's because it's so situationally dependent, it's very positively reinforcing that if you use it in the moment, you get the quick fix in that moment. And then the other side is that actually there's a negative reinforcement that prevents us from quitting. And because you start having the withdrawal symptoms after an hour or two, you feel awful when you're not smoking. And so even if you weren't smoking it for the positive effect, you smoke it so that you don't feel bad when you're not smoking. The other thing about smoking is to appreciate the burden of disease that comes from it. And we all know that it's an expensive habit with serious chronic disease implications and with frequent comorbidities. As there's a huge burden in cardiorespiratory and cancer disease. And when we look at where the burden of disease is lying, we see that, at least from sort of 2010 data is what I presented here, we see that the general population is declining a relatively small amount, but as you move down the socioeconomic ladder, people smoke more, with about a third of people in a low socioeconomic status class and 70% of homeless smokers. And I would argue that this, and depending on where you're looking, this number can be much higher, with it noting up to sort of 85, 90% of people if you're looking at a male homeless shelter. So it's a huge proportion of people who are afflicted by this. So if we know why we should quit, what's making it so hard? And so when we look at the general population data, people tend to know that quitting is a good idea, that there's health benefits. So it's still a difficult process. And when you look at the numbers in the general population, we see that approximately 41% of people have tried to quit in the last year, but only 7% are actually able to make a meaningfully abstinence trial of 12 months. And so almost half people are trying it, but you're looking at, of those people who tried to quit, 10 to 15% of them are really able to make it stick. And certainly we see relapses after a year out as well. And we have many strategies to help with this, whether it be our counseling, our pharmacotherapy, nicotine replacement therapy. But all of them produce only a modest benefit. And that's in the general population. When issues in the homeless population are likely much, much harder to deal with. And so if we think about Homer as being our standard homeless smoker, he has sort of the angel and the devil on his shoulder. And on the one side, he probably knows what some of the benefits are to quitting, but there's all these factors that get in the way. And we've talked about a few of them, the notion of the neurobiology of both addiction and of nicotine. But we still appreciate the health impacts of it as well. How we view ourselves is another notion that's especially important in the homeless population, because when you look at what strategies they actually prefer to use, most people still feel that it's this individual struggle they view themselves and their confidence and whether they're going to be able to make a change is very important in terms of them making that step. The other thing is how sort of culturally and societally both we see the patient, society sees the person, and the person can see themselves. And so there's the cultural issues, but the other added layer on this is sort of how do we see homeless people, and what's our societal views on that in terms of the care that they should receive and how we should help support that underprivileged population. And there's some of the positive things like our family and friends, which can have a great impact on whether we smoke or not smoke. But in the homeless population, these social supports are probably a much lesser impact, especially in terms of their positives, because people tend to have fewer friends, and family supports are often either estranged or very limited. Whereas we have new competing interests to deal with the immediate needs of being homeless. Where am I going to stay tonight? Where am I going to get food? This daily survival struggle leads to increased stress. And these issues are to a much greater proportion in a homeless individual's life and tend to sort of dominate how they think about things in terms of weighing whether they should quit smoking or not. And on top of this, they come and see us, a practitioner, and we say, well, you should really quit smoking, it's affecting your lungs. And then we're frustrated when they don't quit smoking. And so I think it shows how complex this issue is and how much we really have to think about before we're trying to implement strategies, or else we're just setting people up for failure. And so when we look at the general health of the homeless individual, it's obviously very complex and comes down to several different issues. And so if we think sort of the top-down views, there's the individual risk factors and vulnerabilities. So people who have mental health and substance abuse are put at risk for both having a poor quality of health because of those, but also those are things that tend to make people more likely to be homeless. There's also the societal factors, so not having access to low-income housing, lack of job assistance programs, and societal judgments in general, they perpetuate this cycle of homelessness as well. If we look at how health status and homelessness interact, well, it's clear that if your health is poor, both either physical or mental health, then that sets us up for having difficulty maintaining employment and earning a meaningful income, which directly impacts our ability to have a home. And homelessness itself is actually a direct and independent risk factor for poor health, the absence of everything else. But included with this is also the notion that homeless living tends to be at shelters. It's a crowded living condition, which puts us more at risk for infectious disease, tuberculosis. We also have increased exposure to the elements with perhaps inadequate clothing. And then the issue at hand that we're talking about is the notion that just being homeless, we'll see, actually makes it difficult to quit smoking, again, in the absence of everything else. And all of this contributes to a lower quality of life and actually increased mortality. And so for a group of people who have poor health, smoking cessation potentially represents a way that we can help move people to improve both their quality and quantity of life. If if we look a little bit more at the specifics of the health and the homeless, that there's a high burden of nicotine dependence. When there's a lot of survey data around this showing that people tend to start smoking earlier in life, they smoke more cigarettes per day, and they've been smoking for a longer duration. As I talked about, homelessness is actually an independent risk factor for smoking, odds ratio of 2. So in the absence of employment, income, education, mental health, drug addiction, just being homeless increases smoking. Additionally, there is the increased burden of mental health in this population. Up to 2/3 are potentially depressed, significantly more than in the general population. And even when you break down that in the homeless population, we see that actually the non-smokers are less depressed than the smokers. Again, implying that maybe this notion of self-medication with cigarettes may be something that's at play. The other notion is that they have the poor social support, both from their friends and family. But studies have been done to actually look at instrumentally how much access do these people have to social support if they need it. And what they asked people was, how many of you would be able to sort of turn to someone if you needed a ride to get somewhere in the city, if you needed to ask someone for money, like a very small loan, or if your mood got so low that you were suicidal, where would you be able to turn? And what we find is that only about 50% of people are able to answer yes to one of these questions, indicating that when things are really at their worst, only 50% of people feel they have someone that they can turn to. And sort of further on that, if they felt that they had a concern, only 1 in 15 felt that they would be able to find a friend to accompany them to a doctor's visit to provide support in that way. So clearly a high or a low amount of social support. And all of this contributes to a life expectancy that's approximately 10 years less. Now that we've gone through a little bit about sort of smoking and the health in the homeless population, do they actually want to quit, or is this just us trying to push our agenda on them? And so there's one study that looked at focus groups, doing 90-minute focus groups on about 60 homeless individuals who lived at a shelter, and they went through their thoughts on smoking and smoking cessation. And what they found is that most participants were motivated to quit for the same reasons that they are in the general population: financial, social, and health-related concerns. So these were some of the quotes that came out of it that really sort of embodies that. Your breath stinks. Your clothes stink. Your car stinks. You've got the physical appearance of nicotine on your hands or on your teeth. So something that they sort of see these even immediate as well as health concerns. The other notion, so this is from the USA, and so I'm thinking about the cost of health insurance. If you're a smoker, your rates are going to be higher. And a lot of homeless people can't really afford insurance anyways. So again, it's another disincentive for people trying to get out of the homeless cycle, that things end up being more expensive for them. And I think this last quote is especially important. I feel guilty. I'm in a homeless shelter, I've got children, and I buy a cigarette. $2 a day adds up. So this is from someone who is no longer getting all of those positive benefits of smoking. It's making them feel bad that they smoke. They're spending their money on it, which even in small amounts is very significant. And it's potentially possibly actually even getting in the way of their social support. He's admitting that because he's spending money on other things, he doesn't have money to do things with his children. And so I definitely appreciate the benefits of smoking cessation. And we actually see that they're actually wanting to quit as well. And so in another study, they looked at, it was a national study to a 2009 healthcare center survey, which looks at sort of all of the homeless and non-homeless individuals at U.S. federally funded community health centers. Now, this approximately 1,000 people were homeless, and so we have the data from that. And what we see is that over 80% wanted to quit in the last 12 months. And this rate, they broke it down, it's actually very similar for people who are homeless, formerly homeless, or never homeless. And when we look at the general population data, it's also very similar. So we see that the actual desire to quit is there in the population. And we see that people are actually moving along the stages of change model as well. We see that 4% of people are somewhat or very interested in smoking cessation counseling. They're trying to reach out for help. And just over a third are thinking about quitting in the next 6 months. However, despite having these numbers and interest to quit, their quit ratio, which is the number of former smokers compared to ever smokers, is less than half of that of the general population. So even though their desire is there at a similar level than the general population, things are happening about half as well. So now we see that they want to quit, but they're struggling with it. The notion brings up that are we doing our jobs as clinicians? And now obviously our job doesn't simply end at giving advice, but it's a starting point, and it's important to know whether we're actually talking about these topics with our homeless patients in general. And so it seems to be that just over half the time each year, people report that they received advice to quit smoking. That's higher if we had known comorbidities associated with smoking. So numbers aren't great, but not bad, and we seem to recognize that comorbidities of smoking are important to further remind people to quit. And we also seem to realize that homelessness itself is an issue with smoking and an independent risk factor. Because respondents with multiple homeless episodes had a higher odds of receiving quit advice, but still had lower odds of quitting, again, about twofold with an odds ratio of 0.5. So, again, showing how difficult setting up the quitting can be. And again, I say our numbers were okay, but not great, and so it's important to also look back in time a little bit, although not so far back, and see that our old attitudes were not so good. So if we look at, in 1990, the National Health Care for Homeless Program, considering the tendency of nicotine addiction and the deprivations of homelessness, it is unlikely that primary care providers can hope for much success in trying to modify smoking behavior in these homes. In 1992, this was from a homeless shelter director who wrote a letter to a tobacco company. He said, "We do not believe that this is the most appropriate time to give up smoking." And then they asked for cigarettes as donations. 1998, the Symposium on homeless research, again, so our academic minds at the time inherently describe the provision of cigarettes to homeless clients as an initial engagement tactic with real and perceived benefits that promote trust. So if we look back 2 decades ago, we had people who were thinking that smoking was an inherent part of the homeless situation that could not really be changed, and also that we could use cigarettes to our advantage as some sort of outside practitioner to engage and get our goals addressed with the homeless population. So not so great. Then the question becomes, are we doing any better now? And so this is from a 2012 study. This looks at multidisciplinary members of the Healthcare for Homeless Clinicians Network, which is a national organization in the States. They sent out 800 surveys, and they got about a 30% response rate, so not great, but it was still very representative of the network's population. So about a quarter were physicians, and the others were nurses, nurse practitioners, and social service workers. And what they found was that about 75% that tobacco use is the most important health issue for the homeless. And so I think that's probably pretty good, and it's a significant change from what we were thinking before. However, despite this, still saw that about 15% had given tobacco products to patients in order to build trust and promote adherence to care. A third of practitioners knew a colleague who were socializing with patients over a cigarette. So it brings up the question of how can we help people move past their addiction when we inherently undermine our ability to do this by providing them with the addictive substance. So to be a little bit facetious, I sort of bring up the notion of would you think this would happen if the addiction we were dealing with was heroin? Probably not, because we consider that a air quote hard drug. But when you think actually at the population level of the health effects of one drug versus another, I would probably argue that the health effects of the tobacco are significantly more, both in terms of the far-reaching nature of them and the downstream cardiorespiratory and cancer illness burden that people develop. So at least we're trying, though, and we're definitely getting better. So what else gets in the way of quitting? And so right now we know that the homeless population have poor health. We know that smoking's bad. They know that smoking's bad. There seems to be a high motivation to quit. For the most part, we're doing our job at telling them to quit. So what's going wrong? And I think when we think about this, the first thing to discuss is what's happening in the general population. And if we think about where we've come since 1960s Mad Men era to now, considerable measures have been made to denormalize smoking in the general population. We've had legislative changes that have done this. Restrictions in advertising, smoke-free environment policies, and point-of-sale restrictions. But again, for the homeless, they don't see as much of that because in their population, in their environment, smoking is still very much present like it was a half-century ago. And so what are some of the specific things that get in the way? So there's ones that are unique to the homeless population and ones that are important for all of the vulnerable populations. So in terms of the homelessness, we talked about the notion of the competing immediate needs versus the delayed potential for increased health. And that's a very difficult thing to help balance. Because when you're fighting for daily survival, which leads to increased stress that may or may not be managed by smoking itself, it also deprioritizes quitting smoking because of this outlook that the present-day oriented goal of finding survival tasks is much more valuable over quitting smoking, so that maybe I'll be healthier in 10 years. And then the other things that sort of come up is there was one study that did a systematic review of all of the perceived barriers to smoking cessation in the vulnerable populations. And so this looked at low socioeconomic status, indigenous populations, mental health illness, substance abuse, as well as the homeless. And what they found is that across the board, stress management was a huge issue, the lack of professional support to quit, and the high prevalence and acceptability of smoking within their population. So again, the lack of abstinence-specific social support that they can access. Additionally, interesting to note how many smokers people interact with. On average, homeless smokers are interacting with over 40, homeless people are interacting with over 40 smokers each day. And that compares between 3 and 4 people that people interact with, 3 and 4 smokers that people interact with from the general population. And I also like to suggest that it's probably much more than a tenfold increase in influence, because although I may see a couple smokers during my day, they're not part of my social network. But when you're homeless and at a homeless shelter, the smoking environment that you live in is not in your control, and it's something that is significantly prevalent. And when we look at sort of what can help them, if people don't have the support to quit, they're 4 times less likely to even consider smoking. And again, it's not just the social support that you'll have a friend you can talk to. It's someone who's really going to talk about abstinence-specific social support. So back to those focus groups, the homeless individuals also realized this. And so they mentioned, no matter where you go, there's always a group of smokers you can walk up to and start a conversation with. Again, seeing how for a group with low social supports and low social interaction, smoking actually represents a way that they can improve that. Another quote, then you come to a place like this where there's really no rule about it, and so you just go outside. Everyone's doing it, and you take it right back up. And so even people who have had success in quitting, it brings up the question, how can we support them to leave the pack behind where everyone you interact with has a pack and is going to essentially encourage you to smoke. But we've covered a lot of the roadblocks and some of the challenges that we definitely have to face. So we're going to switch gears a bit and say, what can we actually do to help promote this? And so what are some of the positive things that we can think about? And so there was an interesting study looking at what predicts success in and around the time of quitting. And so at a homeless shelter, people were interviewed a week before they expected to quit, and then it was looked forward and saw who actually was able to quit and what made these people different from the ones who weren't able to quit. So we see that those who had the positive affect, they weren't restless, their stress was lower, and they had positive coping expectations. These were the ones who were actually able to achieve smoking cessation. This didn't have any long-term follow-up to it. It was just over sort of the week or two around it. But it shows what are potentially some people who we should be looking out for who who are more likely to be able to move from the preparation to action stage of change. Another study looked at if we offer smoking cessation programs, are people using them and how well do they work? And we found that people are actually lower or less likely to go to these programs. And no one's been able to give a great notion about this, but some of the things that have been brought up is, again, due to the transient nature of the population, it makes appointments difficult. And if appointments are not at the not at the shelter, then it makes it even more difficult. And I can tell you from my experience when I was running my shelter study a few years back, if I tried to sign people up more than a few days in advance, my attendance was often much lower. Again, just because people forget or not around the shelter or doing other things, or maybe have even moved on to another shelter. However, if people actually did go to the programs, they used the programs very similarly to those in the general population, and were significantly more likely to be able to quit. And so for those who actually make it to a program, they can do good things. Another notion is the idea of why don't we just pay them to stop smoking? If you think about this from a health economic point of view, the burden of disease that smoking creates is so huge that small financial incentives earlier on in the pathway may be a very realistic thing to do. And so what this study looked at is they offered people who were already thinking about quitting, told them to set a quit date, and they said they'd give them a $20 gift card if they quit on that day. And then each week that they stayed abstinent, they'd give them another $25. And this went on for 4 weeks. And it averaged about $42 per participant. So if we look at this graph here, where we see the financial incentive line is the dark one, and the usual care is the dashed line, that both at the quit date and at the 4-week after quit date, there were significantly more people who had quit smoking. If we look in the middle, the data doesn't remain significant, but you still have more people who are quitting at or who have remained quit at every data point along the way. And so it essentially shows that this is able to work and may be something that's realistic. Again, if we think from the health economic point of view. Another interesting idea is why don't we extend our similar general population smoking bans into the homeless environment, shelters. So a study from 2015 looked at a large shelter in Dallas, and what it did is it asked people a questionnaire about a hypothetical smoking ban in the shelter. They did this 2 weeks before they actually implemented that ban, and then monitored things over the next 2 months and repeated the questionnaire. So interestingly, before the ban was implemented, about 60% of people supported it, and this support increased after implementation. And you should be able, this ban was for a partial smoke-free space. And so because of that, actually smokers and non-smokers supported this ban to the same level. Non-smokers were more in favor of a full ban, but everyone actually agreed that a full ban would be healthier. And so these homeless patrons are very aware of some of the benefits to these kinds of policies, and they actually endorse it. Some of the potential negatives that people worried about was that would people smoke in different areas where you wouldn't want them to? Would people move to another or change the amounts that they smoke. And what we found is that if you look at in this table, the W1 is the expected effects, so from the survey that was implemented before the ban, and the W2 column is from the actual effects. And so we see that any of the effects were actually quite small, and they all decreased after the ban was implemented. Another side product of this was that even amongst people who were heavy smokers, didn't quit, didn't cut down at all on their self-reported smoking, they actually had reduced carbon dioxide levels in their blood. And so the notion is that we may actually have the secondary effect of, again, reducing secondhand smoke, which may improve the health of people around as well, even if people continue to smoke the same amount. The other notion that is maybe from secondhand smoke, but it also may be in changing how people smoke their cigarettes. Because if there's now a new social environment that people don't need to smoke in, are people no longer using the cigarette as their nidus to start a conversation, and people are smoking less of their cigarettes because they actually want to get back to that non-smoking environment where people are interacting now. Now, the biggest study that's been done was called the Power to Quit randomized controlled trial. And this was a trial that looked at 6 homeless emergency shelters and transitional shelters. And it randomized people to either receive nicotine replacement therapy and motivational interviewing, or nicotine replacement therapy and standard counseling. And it assessed this up to 26 weeks afterwards. And it was a very well-designed study, and actually has 75% follow-up, which I think is exceptional for when you're dealing with a transient population. And so it gave us some more insights into the smoking characteristics of a population. So in general, people were spending about $30 US on cigarettes, or $120 a month. But when you compare this to how much money people actually have, over 2/3 of people said they had an income of less than $400 a month, which means people are spending 25–30% of their income just on cigarettes. A huge proportion of that. The other notion is just around the prevalence, or the marker for nicotine dependence. So the first cigarette within 5 minutes of waking, almost half people required that. And almost 90% were smoking within 30 minutes of waking. As this was a motivational interviewing study, they also looked into the importance and confidence that people had. And people actually agree that this is a very important issue that they need to address. And their confidence isn't actually that bad either. And on average, people were making quit attempts, 2.5 quit attempts in the past year. The other thing that this brought up is it told us a little bit about, again, the comorbidities in the population. And so as in what we would expect, and as we've talked about, 40% or so had PHQ-9 scores that would indicate depression. And over 50% were using alcohol, cocaine, or marijuana. And actually 86% were using marijuana. So that's another high burden of illness, of addiction within the population. So when we go to the primary outcome measure, does motivational interviewing work? I was a little sad at this, as I greatly enjoy motivational interviewing, but they didn't find that there was a statistical difference between usual care with standard counseling and motivational interviewing. However, again, looking at this, we still see that quit rates are consistently higher at all study points in motivational interviewing. So So this has been talked about in a couple of different ways, and it's actually consistent with some of the data that we see in the general population as well. Knowing that motivational interviewing much better treatment geared towards people who are either resistant, angry, or demonstrating low motivational in order to change a particular health behavior. And so therefore, in a population that we see is actually quite motivated, and a lot of the barriers that we've discussed are outside of the patient's control, that may be why we're not seeing as big of a benefit from motivational interviewing. But when we look at who was able to quit, some things became clear. So knowing 5 or more people who actually quit increased our odds fourfold. And so again, this likely implies that it's not just knowing people, it's having people in your corner who are abstinence specific. The other notion was that earning more money helps you quit. And again, this wasn't specifically addressed as to why, but some of the things that got me thinking about was if you're earning more money, that means you're likely doing something to earn that money, and you're spending more time outside of the shelter, more time in a social environment that does not propagate smoking, and you're likely doing something that's more meaningful, and you're less bored from it. And all of these things positively can reinforce non-smoking. The other thing that sometimes we worry about is whether people are going to give up one drug or are they going to take up more of another. And what we found was that irrespective of whether people abstain from smoking, having these interactions actually reduced comorbid substance use at the end of the study. And so people had significantly less drinking days, fewer drinks consumed, less binging, and less use of cocaine. There wasn't any reduction in heroin or marijuana, but there also wasn't any increase either. So people weren't substituting one substance for another. And this likely makes sense due to the common biopsychosocial mechanism that underlies addiction, whereby abstinence from one substance actually helps facilitate abstinence from another substance. And so in 2013, there was a review commentary on the topic in the New England Journal of Medicine. And it summarized a lot of the good strategies that I think are important for us to consider as we move forward trying to help this population. But I think some of the big ones that we've talked about a lot, and ones that certainly we see a lot of the evidence for showing that there may be good strategies for implementing in these are the ones that I've highlighted. And so we think about the individual level. The notion that that homeless patrons have more value on immediate rather than delayed. And so strategies that we need to use to address this is, again, looking at the immediate benefits that patients can receive, both financially or in symptomatic. The other notion is competing life priorities. That is a transient population that's moving around. They have things to do. But locating interventions either at shelters or at the drop-in centers in the environment that they interact with is more likely to produce success. The other notion is, again, on the social level, that it's so pervasive, smoking in the homeless population, that we need to help support groups and peer-based cessation interventions so that can help people within their own environment develop that abstinence-specific social support. And then on the shelter level, I think the notion of applying shelter policies around smoking cessation or smoke-free areas is something that has worked well in the general population and should work well for the homeless as well. So the final line, the final conclusion in this article was the notion that the underlying all of these strategies is the need to change the culture of complacency that has enabled our acceptance of smoking as an inextricable aspect of homelessness. So in summary, hopefully we've been able to show that there's a high burden of nicotine dependence within the homeless population. Smoking cessation represents a way that we can achieve a higher level of health for a particularly vulnerable group. There's a strong desire amongst the homeless to quit, but there's many barriers that are getting in the way. But I agree that we need to make it so that smoking is not the norm. We have some strategies to how we can change this, and we now have the opportunity to help change this. That is it for me, and I will take any questions.
Okay, so everyone who's joined us via teleconference, if you would like to ask a question, you can just push *1 on your telephone to unmute your line.
Hi, can I kind of speak a little bit? My name is Marie Jackson. I come from Kamloops, BC. Can you hear me?
Yes, I can. Go ahead.
Okay. Looking at some of the chat stuff, I should note as well that I have been running a smoke cessation group. Therapy and Jump had an opportunity to be trained in anything that comes my way. But here in BC, and I think it's Canada-wise, but I'm not sure, is quitnow.ca. Are people familiar with that? Quit Now?
I haven't used that one specifically. I know there's similar online help supports.
Well, what Quit Now is offers up 3 months of free NRT, and you get 3 months worth every year. So few of the people were chatting, saying, we need to supply some NRT, and so with that, if you time it, again, confidence is huge, of course, but some people are timing it so they'll do 3 months at the end of the year and then 3 months at the start of the following year. It only does patches and gum. It's not, it isn't, it doesn't include lozenges and inhalers, but for people who are looking for help that way, it's 24/7 online counseling, but it also does supply 3 months worth of NRTs along the lines of patches and gum.
That's very interesting, and you're right, because the financial barriers to some of our station strategies is so huge that, again, as for disadvantaged populations, it's difficult to afford because they cost NRT to be slightly less than smoking cigarettes. Often the homeless population are smoking the name brand cigarettes. They're getting ones that they're making themselves, and so they're able to smoke a similar amount at a much lower cost. And that's
absolutely.
NRT otherwise. And
yeah.
so in Ontario we have the STOP program that CAMH has launched that can help with that. And it's run through a lot of family health teams now as well.
Yeah. Yeah. So thank you. I just wanted to throw that out there for people who may or may not have been aware.
Okay, I'm going to start scrolling through some of the questions in the chat box. The first question that I see here is from Aaron. He asks, would the homeless have already started smoking prior to homelessness occurring, or would the majority have initiated smoking after experiencing homelessness?
I don't have any specific data on that, but most homeless people become homeless during their adult lives, and we know that most people in general start smoking in their teenage years. I saying that most people are smoking by the time they get the homeless shelters.
And he also asks, where are individuals in this population getting stuck? Are the same proportion making quit attempts as the general population?
Yes, it actually is very similar to, again, the desire to quit and attempting to quit. And so I think again, and that's why I think that the motivational interviewing side of things didn't work so well, because they're doing the right things. They're getting stuck, I think, in that relapse prevention stage because they don't have the abstinence-specific social support and the social environment and the home environment that they have, as well as the societal factors that are just completely outside of their control, that they can't modify those. And I think that's where they're getting stuck. And that's why I think that in addition to the building up social support, having mechanisms in place to change policy to treat homeless individuals just like how we treat people in the general population, with having smoke-free bans at places. And we've seen that work wonders in the general population, but we've sort of treated the homeless population as being special and not worthy of these interventions, even though they're probably the most at risk, and we see from some of the evidence that they actually want it.
I'm just scrolling through the chat box. I don't see any more questions. It's more of a discussion here. Oh, here's a question. I am pretty sure that the homeless pick up and smoke more butts than the general population. Since there are added risks from smoking butts, what can we do to discourage?
Absolutely, I would agree with that statement. I don't know, it was one of the, I don't know the exact percentage. I think it was something like 20 to 30% of people often re-smoke buds. I think in how you address that is that smoking cessation in general. That if people need that nicotine for one reason or another, and they're smoking, and they can't afford cigarettes, then buds are what they have to work with. And I don't think that that is likely to change from a viewpoint of can we change what they're smoking. Unless you wanted to, again, do the harm reduction of providing cigarettes. But again, that obviously has health implications as well and would probably not be a great strategy. And it a little bit more upstream that we have to do things to help with the smoking cessation itself so that people aren't having those urges and requiring that they smoke buds in order to maintain their physiologic levels of nicotine.
Can I mention one more thing then?
Of course.
Thanks. One thing I've discovered in our groups is to lay off some of the pressure around going cigarette-free and noting the difference between smoking and being nicotine dependent and what is the actual goal. So it's really nice to set a goal of not smoking cigarettes, which is of course, and cigars and that, which brings on all the carcinogens, as opposed to just maintaining the nicotine dependency. My population that I work with is some of them are homeless for sure, but it's mostly with people who are schizophrenia, bipolar disorder, profound depression. I'm a case manager in psychiatric nursing, and so and we're very accepting of the nicotine dependency, and I'm trying right now to appeal to support people who are in need of ongoing gum or something like that, and just get rid of the cigarette element of it, and just kind of, now some people still want to be nicotine free, and I support that too, but I think it's really important to say we will help you. And I really am working right now on that particular movement.
Yeah, and so I think that's great. It sort of embodies the kind of harm.
Oh, I can't hear you anymore. Shoot.
Can you hear me now?
Yeah, I can. Thanks.
Saying that it's the harm reduction approach that also is a great strategy. Smoke, like the chemical addiction from nicotine, we can address in a much safer way, even if people stay on nicotine replacement long term, which is much healthier than people smoking long term.
Yeah, I think that needs to be seen as a legitimate goal.
That's a good idea.
Yeah, thank you.
Okay, so we're just about out of time now, so I'm just going to move along. Feel free to continue typing in your questions or email me if you have any further questions about the webinar. Thank you everyone for attending today's session. As a reminder, in order to receive a letter of completion